All right, good afternoon, everyone. Thank you for joining the Clinical and Translational Science Collaborative of Cleveland, also known as the CTSC, for the first challenge in our four-part Mission Health Equity Challenge series. The CTSC is a collaborative among Case Western Reserve University and its affiliated hospital system, the Cleveland Clinic, MetroHealth, University Hospitals, and the Lewis Stokes Veterans Administration Medical Center. We aspire to be a catalyst for high-quality clinical and translational research, both locally and nationally, by changing the culture and environment of biomedical research, sharing resources and expertise, and streamlining the research process to move translational research from bench to bedside and to the community. We co-hosted this film screening of and panel discussion about the Color of Care documentary produced by Oprah Winfrey's Harpo Productions and the Smithsonian Channel with the Western Reserve Historical Society, a Smithsonian affiliate. We will launch our panel discussion with remarks from Dr. Charles Modlin, Medical Director of Equity, Inclusion, and Diversity, and begin the formal question and answer session that will feature Dr. Modlin, Alan Nevel, Senior Vice President and Chief Equity Officer, and Margarita Diaz, Director of Equity, Inclusion, and Diversity, with a range of expertise in health disparities, diversity, equity, and inclusion, quality improvement, and overall advancement of health equity. Please feel free to add questions to the chat throughout the discussion. We will attempt to answer all questions, and if we run over on time, please feel free to depart when needed. Again, thank you for your time and attention, and let's meet our panelists. Dr. Charles Modlin, MBA, MD, is a staff urologist and medical director of the MetroHealth Office of Equity, Inclusion, and Diversity. He joined MetroHealth in September 2021 and was formerly at Cleveland Clinic for 28 years as a kidney transplant fellow, and then as a member of Cleveland Clinic's surgical staff as a kidney transplant surgeon and urologist. He founded Cleveland Clinic's Minority Men's Health Center, and in 2003 established Cleveland Clinic's famed annual Minority Men's Health Fair that has provided free health screenings, health examinations, and health education to nearly 35,000 predominantly African-American males for the early detection of disease to save lives. MetroHealth will conduct its first Minority Men's Health Fair April 28, 2022, so that occurred this year. And in 2011, Dr. Modlin was named by the Atlanta Post as one of the top 21 Black doctors in America. Dr. Modlin was the first African-American staff urologist in the history of Cleveland Clinic and the first and only ever Black transplant surgeon in the history of Cleveland Clinic. Alan K. Nevel is Senior Vice President, Chief Equity Officer for the MetroHealth System. In this uniquely integrated leadership role, Alan is responsible for defining the overarching vision, identity, and strategy to ensure that equity is the underlying central principle in all that the system does. Alan and his team's primary focus is to work across administration and MetroHealth's departments, programs, and initiatives to eliminate systemic disparities and inequities that impact patients, employees, and the community. A native Clevelander, Alan brings over 25 years of experience in successfully guiding large Fortune 500 organizations through large-scale cultural transformation. Alan's management expertise includes driving the development and implementation of value-added, best-in-class strategies in diversity, equity, and inclusion, human resources, organizational change management, leadership, talent, and workforce development. Margarita Diaz leads as the Director of Health Equity, Inclusion, and Diversity for the Office of Equity. She is a leader for advancing inclusion, diversity, and equity for the MetroHealth system, impacting employees, patients, vendors, and surrounding communities. She implements strategies that align and promote the health system's mission and proactively and strategically addressing health disparities and inequities with a focus on underserved and underrepresented communities. She executed a 5-year strategic plan incorporating health equity system-wide. She leads a team under the Office of Equity overseeing planning, design, and implementation to system programs, education, and engagement at all levels and multidisciplinary roles from frontline to executive leadership, ensuring that the MetroHealth system is well equipped to serve diverse populations equitably. All right, Dr. Modlin, the floor is yours, and I will advance your slides.
Oh yeah, thanks. I hope everybody can hear me okay. I'm going to be actually very brief because I'm laughing. Oprah stole my thunder. She presented most of what I was going to talk about, but when Oprah speaks, people listen. So we're really happy that Oprah has taken this her awareness about these health inequities and brought it to the forefront of the entire nation. So we're really grateful for this video, being produced. On the screen is my contact information. I'm available for any of you to reach out to. That's my personal cell phone. You can call me, text me. That's my MetroHealth email. I've been here for a little bit over a year. I'd like to thank Alan Nevel for inviting me to be part of his team. It's a pleasure to work with him, LaShawn, Margie Diaz, and everybody else. So you can advance my next slide. So this wasn't necessarily emphasized in the video, but we all know this, that the demographics in the United States are rapidly changing decade by decade. And we see this in the US Census Bureau. But the point I want to make here is in the next 10 years, 20 years, the minority percentage of the population is going to become the majority. So what you heard about all of these health disparities that are disproportionately afflicting people of color, even though now they're afflicting the minority percentage of the population, in the next 10, 20 years or so, it's going to be the majority percentage of the population. And I highlight this because this healthcare inequity disparity situation needs to be elevated to what I call a national crisis awareness state. This is something that we have to solve. And even though we've been working on this for a while, we need to accelerate our efforts nationwide. Next slide. So this is just the definition of what is a health disparity. You can click on those. So these are the four required components of what is a healthcare disparity: a higher incidence or prevalence of disease, earlier onset or faster progression, poorly daily functioning, quality of life, excessive premature mortality, and a greater global burden. And when we're talking about health disparities, we're talking predominantly in people and communities of color. Next slide. So these are just some of the common health disparities. Oprah mentioned a lot of these in the video. You can just click through those: higher rates of hypertension, diabetes, heart disease, kidney disease. I'm a urologist. One condition that I diagnose and treat is prostate cancer, which occurs twice as often in African-American males, kills twice as many Black males compared to their white male counterparts. Next slide. And a lot of these disparities are even occurring in our adolescents, our youth as well. So what I wanted to do, and there's a reason why I'm showing you several different examples of some of the healthcare disparities that are pervasive throughout every specialty area of medicine, is something that I'm going to present to you very briefly at the end. So you take the incidence of colorectal cancer and even screening, referrals for screenings for colorectal cancer. You can see that Latino Americans, African Americans are less likely referred and less likely undergo colonoscopies to screen for colorectal cancer. So racial and ethnic disparities in colonoscopic examinations exist, and we need to, be aware of this and make a greater concerted effort to educate the community about the importance of colorectal cancer screening. Knowing one's family history is very important as well, because there are genetic hereditary components as well as many social determinants of health that contribute to that. Next slide. So this was also presented in the video, and many people were not aware of this. Many physicians were not necessarily aware of having a coefficient to that was part of the calculation for GFR, glomerular filtration rate, kidney function. It was based on faulty research and faulty assumptions several decades ago that African Americans had a greater muscle mass, and therefore in calculating kidney function, there should be a coefficient added into that calculation. And it was touched on in the video that this actually negatively impacts African Americans' ability to be listed as early as their Caucasian American counterparts to receive kidney transplants. And so I know MetroHealth has actually recently gone away from using this race-based coefficient in calculating GFR, and that's very important. Next slide. Next slide. We've talked about the kidney transplant disparities. You can go to the next. So I mentioned that a lot of these disparities, and this is very disturbing, are also affecting our youth, including anxiety, stress, depression. In recent years, we've also seen, and this is very disturbing, higher rates of suicide in both Black boys and Black girls as young as 5 years old. And I would have never imagined that. Next slide. Oral health disparities. There have been research and studies demonstrated that minority children were significantly less likely to have their practitioners focus and concentrate on their oral health. And we know that's very, very important. Unmet oral health needs can actually lead to systemic disease, including a cardiac disease. Next slide. A greater incidence of fibroids in African-American women compared to whites. Again, next slide. I'm just going through these just to highlight some of the examples of health inequities that we see across the different clinical service line specialties. Differences in terms of physician, healthcare provider recommendations as to whether or not somebody following an orthopedic injury or condition should have be relegated to medical therapy versus surgical therapy. This is a an article that I was a co-author on that looked at cultural biases in terms of medical decision making. Next slide. So this actually is also very disturbing, and this is the British Medical Journal article. There's other articles, more recent articles, but it demonstrates that African Americans, ethnic minorities seen in emergency rooms are relatively undertreated for pain. A lot of times, and again, this has been documented over and over again, it's many clinicians feel that many minorities, when they go to the ER, are just drug seeking. And this is even seen in patients with in sickle cell crisis. Sickle cell crisis can cause systemic pain, joint pain, abdominal pain, and so this is very disturbing. We need to look further into this. Next slide. So again, the ER, we're not trying to pick on the ER, but when individuals of racial and ethnic minorities go to the ER and have a similar diagnosis or suspected diagnosis as a Caucasian American, African Americans, minorities are less likely to be offered or ordered a diagnostic imaging in the ER. Chest X-ray, CT scans, MRIs, again, needs to be looked into further. Next slide. Common skin conditions. Many skin conditions are more common in African Americans. Next slide. I won't go through that now. The eyes, again, all of the different organ systems are essentially affected by a lot of these health disparities. Higher incidence of glaucoma. We know that untreated glaucoma can lead to blindness. Again, there can be a hereditary component in that as well. Next slide. Hearing loss. That's another huge disparity. Actually, a lot of that relates to social determinants. A lot of us work in noisy environments, factories, foundries. And so again, that's another health disparity affecting, the hearing. Gets into ENT. Next slide. Alzheimer's, higher incidence, less likely diagnosed, but a higher incidence in African American and Hispanic populations. And this is something, again, that we need to relate to our families. What is our own personal medical history? So our families will also be likely, will understand more that what their likelihood of contracting a certain disease is. In hereditary conditions, there are different variants and different penetrants. And so just because a family member had a certain particular condition doesn't automatically mean that you will yourself suffer that condition, but you need to be aware of it. Next slide. Obstructive sleep apnea. Again, talking about our children, African-American children, 4 to 6 times more likely to have obstructive sleep apnea compared to white children. We know that can cause premature mortality. Next slide. And these are, a lot of these things are things that we don't normally commonly think of. Higher incidence of fatal drowning for kids. That's a health disparity. It relates back to a lot of the social determinants where Blacks were not allowed to go to public swimming pools. Research has actually shown that when African-American adults, or any adults for that matter, don't know how to swim, their children are less likely to know how to swim as well. Kids ages 11 to 12 are 10 times more likely to drown than their white counterparts. Next slide. Number of missing persons is disproportionately seen in Blacks, especially Black women. Another healthcare disparity. Next slide. So I just wanted to cover very briefly what some of the examples of the health disparities, and the documentary covered it beautifully. But to put things into perspective, even though our longevity, our life spans are increasing, our life expectancy decade after decade, you can see a persistent 6-year, 7-year survival gap between Black females, males, and their white counterparts, despite advances in medical technology. Next slide. So this was talked about. Where you live, your zip code actually determines how long you live. And this is actually Cuyahoga County data. There's other data across in other states and different counties. So if you live in the Huff neighborhood, for example, your life expectancy is about 65 years. Whereas if you live 5 miles away in Shaker Heights, your life expectancy is about, these are average life expectancies, about 88 years. You're talking over 20-year differential life expectancy living 5 miles away. A lot of it we know that about 80% of the disparities are related to social determinants, poverty, lack of jobs, unemployment, being uninsured, living in food deserts. All of this contributes to a lot of the social determinants that we see. Lack of transportation. Next slide. So why the healthcare disparities? So it's not enough just to hear about the health disparities. It's important to have a working understanding, operational understanding as to why they occur. There are many multifactorial contributing causes. There are healthcare provider causes, health system causes, patient contributing factors. We talked about social determinants, poverty, lack of education, lack of health literacy, knowledge and awareness in terms of how best to take care of yourself, what type of screenings you should have at what age. The video was crystal clear with respect to historic factors, distrust, and how that actually contributes. And we all understand, the importance of being empathetic and understanding where people are coming from. Proper communication, listening to patients, all that has to be put in perspective, because we have to develop better trusting relationships, better rapport, better communication with these target populations, these healthcare disparity populations, if we're going to move the needle and improve the trust that is needed. I believe that lack of diversity in the healthcare workforce is a significant contributing factor. Only about 4% of physicians in the United States are African American, about 6% Hispanic Latino. I think, and we've been spending a lot of time in our office. You're going to hear more from Margie and Alan about some of the pipeline projects we're working on. Genetic biologic predisposition, lack of minority participation in clinical research trials, obviously, because of Tuskegee and other egregious actions. And I actually think, and I've never heard anybody mention this before, I think the subspecialization in medicine contributes to the health disparities, because a lot of times when, again, I'm not trying to pick on any subspecialist or anything, I'm a subspecialist, but a lot of times when patients will come in and see a subspecialist, that subspecialist is not even aware of what their blood pressure is, had they had a particular screening, prostate, colorectal, so we can't leave everything, the onus is, we can't just leave it on the primary care providers to try to assess the patient. We need to actually participate and facilitate in the overall care of the patient. So I think that actually contributes. We're physicians, we're advanced practice providers, we're RNs first before we become specialized, and we need to remember that. So next slide. Next slide, we heard about Tuskegee. That's an actual picture. Structural racism that actually has been borne out since the death of George Floyd. It actually contributes to a number of the existing and ongoing health disparities that we see. That's an article from the American Heart Association. Next slide. So chronic stress, a lot of these stressors, insults, micro insults, overt insults, the chronic stress in which many underserved populations, minorities experience over a period of time actually increases one's circulating cortisol. And you can see higher rates of cortisol can actually adversely affect all areas of the body: your brain, your heart, your GI system, pancreas, kidneys, reproductive organs, hypertension, diabetes. So we don't want to forget about the importance of addressing one's mental health issues, but the point is stress, anxiety, depression can actually be realized by the onset of physical infirmities as well, not just mental infirmity. Next slide. So this was actually touched on unequal treatment. Next slide. Between minorities and majority populations. There was a study that demonstrated that 5 times as many lives could be saved by correcting for the disparities between Black and white individuals than in developing new treatments. Next slide. So we need to provide the same quality care for individuals regardless of their race or ethnicity. So again, it's not enough to just recognize the health disparities. It's not enough just to understand why they occur. We actually need to come up with solutions, and otherwise we're not going to solve or mitigate against these health disparities. So one thing that we've and we have a number of solutions and ongoing programs, and that's why I wanted to highlight some of the examples. And so April the 28th this past year, we conducted the MetroHealth's first Minority Men's Health Fair, open to everyone, regardless of race, ethnicity, gender. We had about 1,000 individuals attend from this health fair. And again, a number of individuals that come to the health fair, they actually have access to care. They do have insurance, not everybody, but a number. But a number of individuals feel more comfortable accessing the healthcare system, undergoing screenings through this named program. It's been widely successful, and we're going to continue it. We'd hope that each and every one of you will sign up to volunteer. April the 27th next year, that's the last Thursday in April, between 5 and 8:30 p.m. If you want to volunteer, all you have to do is tell your supervisors. We've already worked out a situation that if you have to travel to one of the 4 health fair locations, you will be given permission to cut off early from where you are and go to the health fair. So we appreciate what we've all done to make this past health fair successful. Next slide. So next slide. So it's important. People say, well, we don't really know what race is, but if used responsibly, race can be used as a surrogate marker that the likelihood that a given individual or population has a higher incidence of disease. Take African-American males. As I said, we have a higher rate of prostate cancer, dying for prostate cancer. That has actually led to the recommendation that Black men should start screening for prostate cancer 15 years earlier than their white male counterparts at age 40 versus age 55. That is race-based therapy. I talked about how in estimating kidney function, the research didn't back that up, that rationale, but there are instances where we should be looking at race as a surrogate marker. So we don't want to throw that out, the baby out with the bathwater for that. So next slide. So again, I encourage you to go online, type in MetroHealth Minority Men's Health Fair video. You'll see footage of the event, patient testimonials as to why it's important. Next slide. Which leads me to what I want to finish up on. So I talked about how it's important that we actually intervene to create substantive programs to address these healthcare disparities. And we're going to need all of your support, every one of you on this call and others. What we're doing, we're going clinical service line, department by department, specialty by specialty, and we're looking at the health disparities that are more likely to occur, whether it's in endocrinology, diabetes, kidney, cardiovascular disparities, lung, GI, neurology, stroke, urology. Each one of these areas, these departments exhibit certain higher rates of disease along racial and ethnic lines. And we've spoken to every clinical service line department director, their diet administrators and others, and we're developing what we call multicultural health centers of excellence. We just kicked off our urology component to that, our Minority Men's Health Institute. So we're looking for all of you to participate, physicians, advanced practice providers, nurses, everybody within the health system, no matter what your job description is or what your title is, you can actually play a significant role. We're going to have town halls to describe more precisely in more detail what these are, so you can better understand what it is we're doing. But this is very important because we're first movers in this at Metro, and we've been doing a lot of this work for a number of years. And this is really the best way in which to better engage the community, improve their health literacy education, build the trusting relationships that we know are very important. I want everybody to, as I close here, we all understand and we understand what is the importance of that all healthcare providers be empathetic. But actually empathy is not enough. We need to take it one step further. Look up the difference between empathy and compassion, because they're very different. And I'm going to read the definition here. Empathy and compassion are very different. They're represented in different areas of the brain. With empathy, we join the suffering of others who suffer, but stop short of actually helping. With compassion, we take a step away from the emotion of empathy and ask ourselves, how can we help? So empathy is important, but I think it's even more important that we all take a stand, become active in this battle against these health inequities, and that we become more compassionate to the plight of these health disparity populations. So with that, I want to close and thank everybody for allowing me to present today, and I look forward to hearing Margie and Alan. Thank you.
Thank you, Dr. Modlin. Our first question in the chat reads, in hindsight, how could our healthcare systems have been more prepared to combat COVID? And if you would like to touch on specific examples of how MetroHealth did do some really good work in terms of combating COVID and supporting the community as it pertains to both of your roles, I think that would be really interesting. So
yes. Yeah, so for the majority of the pandemic, I actually wasn't present at Metro. I mean, Margie and Alan would know more, but one thing that I do know, when I was at another institution, I was actually quite jealous in terms, I would see on the news, MetroHealth just screened 1,000, patients in the community for COVID, and I couldn't understand how they were able to do what no other institution in the city could do. A lot of it, I know Dr. Brooke Watts led a lot of those initiatives to screen the community for COVID. But again, that's just another example of where MetroHealth was, best practice. What could we have done to be better prepared? Nobody really saw this pandemic coming. There were lessons that were learned as we went, along. Everybody was learning the lessons at the same time. So, I'm not going to be critical. I mean, were mistakes made early on? I don't know. I mean, there's a lot of controversy in the media and things like that. But all I can say is MetroHealth took the lead and set the example for everybody to follow.
Thank you, Dr. Modlin. What do you think, Margie? And then Alan, if you'd like to add some commentary as well, and then close out with final remarks.
Actually, thank you, Jalise. Actually, I'm going to kick it over to Alan. Um, no problem. So, when we think about the fact that for the COVID vaccine, the uptake or acceptance of the vaccine, particularly within communities of color, was at a much lower rate. There were a couple things that we did within MetroHealth that I think were what I consider to be best practice. We had employees of color who were uh, very much focused on sharing their why around the vaccine. So we created videos that were shared both internally and externally with employees of color saying their why in terms of getting the vaccine. We also engaged the faith-based community because we do know that in communities of color, the church, and I'm using that term very loosely in terms of across multiple religions, denominations, et cetera, spirituality still remains a key focus in many communities of color. So we leverage faith-based leaders. In fact, having faith-based leaders who were well into their 80s and 90s sharing their why. So we did those things, as Dr. Modlin had mentioned earlier. Dr. Brooke Watts and team went directly into the neighborhoods, into the community to meet people where they were in order to begin to build that familiarity, comfort, and trust that's so important for us as clinical providers to have that trusting relationship with our patients. I think about the work that Margie and her team and our entire Office of Equity is doing in order to accurately represent the MetroHealth system as that trusted partner. But as we get very, very close to having to wrap things up, I just think it's interesting to me. I looked at the chat, and at its peak, we had 86 participants in this chat. So I'm putting something in the chat for everyone to look at right now. If what you saw over the last nearly 2-hour experience upset you, if it left you feeling sad, depressed, whatever human emotion you felt, I think it's all summed up into man's inhumanity against man. And ultimately, every single one of us on this call is a human being. That's our shared experience. And I know that Oprah referred to that as well. And I really think when we look at healthcare disparities, at the end of the day, you strip away what you see or what you think you see on this screen. I'm made up of the same stuff as anybody else on this call. So if there are 86 of us on this call, if each one of us reaches 5 people and they reach 5 people and so on, we can touch and we can truly impact the healthcare disparities in Greater Cleveland very quickly. I did the math, that's 67% of Greater Cleveland. So it's really up to all of us. And I know we've got folks who are on the clinical side of the house in their respective institution. We've got academic folks. We've got folks who are on the operational administrative side. But if all of us reaches out and touches someone and begins this dialogue with 5 people, we can literally go viral and we can change these devastating outcomes in our community. You think about what they said in the video very quickly. They talked about Jackson, Mississippi. There's a water crisis in Jackson, Mississippi. Guess what? Jackson, Mississippi is 80% Black with a 24.5% poverty level. Think about what happened in Flint, Michigan. Same thing, majority Black city, 40% poverty rate. So all of these things fit together that create those disparities that Dr. Modlin talked about. So ultimately, we have a decision. We can either have a feel-good moment on this call, or we can all take action, because all of us have power, and together we have even more power. So with that, just want to thank you.
And I'd like to say a few words, if those who can hang on a few minutes. I know we're well into the 2 o'clock hour, but first of all, thank you, Jaleese, for reaching out to the MetroHealth system. Thank you, Dr. Modlin and Alan and the equity team for being wonderful partners in moving this work forward. And I do want to be respectful of the plethora of emotions that people may be feeling. And so I want to be respectfully empathetic about what people may be feeling. And you may be feeling a range of emotions from overwhelmed to anger, right? And so we are aware. I also want to say that I want to thank you all for being here. Alan said there were 85 people on the call. You were here because you cared enough, because you were bold, because you were courageous. And so the call to action starts with you. The first step is, what are you going to do? It is an overwhelming situation. We can't boil the ocean. It is overwhelming to resolve. But as Alan said, each person can impact their sphere of influence. We all have circles of influence. I love what Oprah said, and I will leave you with that. And it really, really isn't, although there's a lot of science behind this, we understand that with data, but really, really, and they said, a couple people said, it's as simple as, are you looking at someone in the eyes? Are you smiling? What's your posturing saying? Are you gentle? Are you kind? That it doesn't matter what age, what sex, your academics, your socioeconomic status. What I heard throughout this video is, how are we being kind to one another? How are we connecting culturally? Because a smile is universal. A touch of the hand is universal. That is culturally competence. Will we ever arrive? No. Will we save everyone? No. Let's be realistic. But you can help the person that's in front of you. And so it does start with you. And so healthcare providers, I want to say this, you take an oath, do no harm. And I love, that was powerful for me. And I want to close with that thought, or we're going to stick around. There's more questions. I have time. But for those of you, do no harm is not enough. And that was the one thing that stuck out for me. We are a 185-year-old organization. Our mission is about people, the underserved, underrepresented. It has been for 185 years. What we've done in the last couple of years, what Alan, his leadership, Dr. Modlin coming in, and now the equity team, what this work has done still is not, we have a ways to go. So I say all that to say that there is progress, but we have a lot more opportunity to do. And this is not to make anyone feel bad. This is about, how can we do it better? This is not challenging anyone's authority or your credentials or your title. This is wherever you are in the system, from sweeping the floor to in the C-suite, we all have the ability to impact lives. And it doesn't matter if you're not in front of the patient, you pass patients every day. And guess what? We're somebody's patient. So if you don't think you work with patients, think again, because everyone here has physicians. So you're somebody's patient. So I'm going to pause there because I see a couple of questions. And again, I want to thank all of you for taking time, for being bold. It takes boldness and it takes courage. And you all were courageous enough, and self-awareness. Programs like this, read books, watch documentaries, unconscious bias sessions, all of that starts with awareness. It starts with you. Thank you.
Thank you, Margie. So the question from the chat was, although I know this does not alleviate or mitigate the racism experienced in our healthcare system, do you believe if the United States adopted universal healthcare coverage, such as other countries like Canada, that the separatist quality of care based on race would be different?
It's my understanding from some of my colleagues who live in countries where they do have universal health care, some of the biases exist either way. The perception of, for instance, African Americans can endure a higher level of pain. I don't think that has anything to do with what healthcare is provided. If you're not given a prescription because you are assumed to be able to endure more pain, I don't think that really makes a difference in terms of whether you have insurance or not. I think we have to really bust the myth around these stereotypes, these perceptions. If you think about what has led to modern day OBGYN, back then it wasn't about insurance. The experimentation that was done on Black women in order to quote unquote advance science, whether you had insurance or not didn't have anything to do with it. So that's just my perspective. Again, I'm not a clinician. I think we as human beings have to, again, realize that we're all on this earth together. And the color of my skin still makes me just as much as a human being as someone who might be lighter or darker than me. I think that's what we really have to align on. This is not a Black issue. It's not a white issue. It's not a brown issue. It is a human issue that needs to be changed. And the only way we can do it is for all of us to do it together. To Margie's point, we have to realize that in our respective healthcare systems, every single person is responsible for that patient experience, regardless of whether you lay hands on them or not. And thanks to everybody for staying on. I know we've gone over, so I just want to extend my personal thanks to you.
Yes, thank you.
And thanks MetroHealth for representing well on the call.
Another question, how do you think we could explain structural racism without receiving reactions such as, I'm not racist? Do you think we should use more metaphors to explain it?
In our organization, what we did shortly after the murder of George Floyd was we went directly to what the issue was. So rather than typical diversity, equity, and inclusion training, which touches on social styles, communication styles, all the soft stuff, we went directly to systemic racism. And we had to rip the Band-Aid off and call it for what it was. So we started out at the system board of trustees level, as well as our foundation board, because you have to start at the top of the house if you really want to affect change. And we took our system and foundation boards, as well as our senior leadership, through 6 hours of deep immersive education, where we showed very graphic images of what has transpired due to racism in this country. It was not done with the intent to cause anyone to feel personally responsible for what had happened, but it was intended to create a level of personal responsibility for what happens for this day going forward. So as I mentioned earlier in my call out to the group, if what you saw in those images of Emmett Till, those images of strange fruit hanging from the poplar tree, the images of the tools that were used on enslaved women to advance science, quote unquote, if those things disturb you that much, what are you going to personally do in your sphere of influence? Like I said, 86 times 5 times 5 times 5, ... What are you personally going to do to change the narrative for our children and our grandchildren and all of those who come after us? That's the question.
I'd like to address the statement, I'm not a racist. This is what I would say to that. No, but we are all biased. We are all biased. And so our unconscious bias sessions that we have is called, we all do it. And so it starts with realizing that we have bias. And so, it's if the person doesn't acknowledge that, then that's, I would cut that conversation short, right? That's a moot point. But when we are aware that we have biases and that we're all biased, and that, again, this is a continuum. You can practice equity, inclusion, and diversity for many years and still have biases to mitigate daily, right? And so acknowledging those biases, I'm going to steal your line, Alan. When you know better, you do better, right? And so when we acknowledge our biases, that's step one. I always liken this, and no offense to anyone, right? But 12-step program, what's the first step? If you go to AA, the first step is acknowledge that you have a problem before you could fix it. And I want to say that the reason why the MetroHealth system is having such uncomfortable conversations is because we cannot get to a solution if we're not willing to look at the problem. And so we come from a culture where, perfection and what we see and, bigger and better and best. And so we tend to be, our humanity is to hide those things and, hide behind roles or titles or, and so we have to get, it's cultural humility. And that's really hard to do, to be culturally humble and to take a look at oneself on a regular basis, on a daily basis, to say, what could I have done better today? So I think that is really the crux of it all, is the self-work. You have to work on yourself first. It's like, when you're on an airplane, who do you put the oxygen mask on first? Yourself. So this work takes a lot of personal self. And so you can go at your own pace. If you can only stomach little, I'm putting visuals there. If you only can take a little bite at a time, and that's all you can chew, that's okay. But you go at your own pace, and some move quicker. So that is the freedom of being, of this personal journey. It's how much you're willing to invest, because it's like an empty cup. The more my vessel is full, and if I start to run over, everybody else is going to get some of it, but you got to fill yourself up first. So yeah, I'll stop there.
Thank you, Margie, Alan, and Dr. Modlin. We really appreciate your time, talents, expertise, and just willingness to collaborate. Thank you, LaShawn. And on behalf of the Western Reserve Historical Society and Clinical and Translational Science Collaborative at Case Western Reserve University, we appreciate all of your time and attention, especially the excess time here as we approach 2:13. Thank you again for supporting health equity by attending the Color of Care film screening and panel discussion. You'll be receiving a post-event survey that we'd appreciate you completing. And we also hope that you will sign up for some other challenges that are in our Mission Health Equity Challenge series. Thank you again, and have a great afternoon, everyone.
Thank you.